Tissue Integrity, Part 7, Introduction to Nursing Concepts, Martha Olson. When we look at tissue ischemia on page 1177, very good to read. That term called reactive hyperemia. It's pressure over a capillary that exceeds what normally the capillary pressure is, and then that vessel is occluded for a long period of time. That's why repositioning our patients is very important so that we don't have this happening. Reactive blanching then is when you push down on the skin and it dilates in response to that tissue trauma that happens. So blanching means it turns lighter in color, and then the reactive blanching, it turns red when the pressure is removed to that area. You've probably seen that in yourself when you sit on the floor Indian style with your legs, and then when you stand up it's bright red as a result. Non-blanching is severe tissue damage, and that's where it doesn't become red. It's the no lighter color when the finger is pressed against it, and there's deep tissue present, damage. We need to differentiate between the blanching and the non-blanching. The timing of this, any redness lasting longer than 15 minutes can indicate hypoxia. If hypoxia time is 30 minutes with a turning interval of 2 hours, increasing turning time to every 1.5 hours is going to only help the situation. So again, when we have patients that have this capillary pressure that is not allowing the blood flow to the tissues, we need to increase what we're doing as nurses. In looking at nursing diagnosis, some of these are very nicely written, and as you read them, some of them you will see probably aren't the best. As we look at our nursing diagnosis, we think of which one is our priority. And for me, it's the one called ineffective tissue perfusion, because it's talking about tissue that's not getting oxygen. Number 2 is impaired tissue integrity, and number 3 is impaired physical mobility. Our planning then becomes part of what we do, setting our goals, that they're patient-centered, they're realistic, and they're measurable, and we work with others trying to promote the best for the patient. Other problems that we see: are they on steroids? Are they immunocompromised? Do they have a peripheral vascular disease? And then realistic is keeping blood sugars maybe 150 or less instead of the usual 70 to 120, but is that a realistic? Our implementation starts on page 1206 in Potter and Perry. Keeping the skin clean and dry, applying a moisture barrier cream, frequent assessment and turning. The 30-degree lateral position we have coming up, and that's going to be important to get the weight off of the bony prominences, avoiding our shear injury, not having them sit up in the chair too long. And in the book, also on page 1206, which is new for Potter and Perry in this 8th edition, is looking at that negative pressure wound vac. That negative pressure wound therapy then helps with closure of some of our very nasty wounds. It's being used more commonly today. And the other thing I'm noticing is families are having to help with these wound vacs because these people are at home. A good friend of mine, her husband had some pretty extensive abdominal surgery, and she had to maintain that wound vac at home. The biggest key to that is the good seal for it to work, because it works under negative pressure, pulling the fluids out and promoting the healing. That negative pressure draws the edges of the wound together, and that healing of the granulation tissue then lines that surface and helps them. As you look at this person in the bed, this is what we call a Montgomery strap. It's a non-adhesive portion that goes over that. So under that white square is the wound with the dressing. And then we put this Montgomery strap, so when they have a lot of drainage, we simply untie those 3 little ties in the middle. The flaps come back that are attached to the skin away from the incision, and then you change the ABD or the dressing over the top, and then close your straps again and tie them. The best thing about the Montgomery strap that you see here is you don't have to keep changing the tape to an abdominal wound that we have. This PowerPoint is also talking about our bandages and binders. We don't see a lot of breast binders used anymore. Years ago they used them in OB for women that were not going to breastfeed. but we don't use them. 1209 is where it starts. You need to write on your note cards as you study, what do I as a nurse do before I apply a bandage or binder? What do I need to assess when they have one on? And then what do I need to assess to say this needs to be removed? I need to call the doctor. Before applying them, always look at the skin. Would you want to put a binder or a bandage over a wound or an open area? Is there good circulation to that extremity? If you have a cool, pale, cyanotic, no pulses, swelling, numbness, tingling, is it appropriate maybe to apply these? Probably not. For the chest binder, remember in the oxygenation unit we talked a lot about taking good deep breaths, promoting oxygenation all the way to the bottom. Well, when you bind the chest, it can impede taking good deep breaths. And so when you have to put a chest binder on, make sure they take a deep breath, hold it, and then you apply it so you know that they have maximum expansion to those lungs. With chest binders, remember if they're too snug, you can decrease air exchange. Gone with the Wind, where the girls in that wore the corsets that were too tight, many of them would pass out as a result of lack of oxygen from their dresses that they wore in the South in Gone with the Wind. And then your sling, look at where on that picture the pressure is, and it's behind that man's neck, because the weight of that sling is going to fall onto his neck, and you're going to look for skin breakdown and skin issues then to the back of his neck. The elastic binder over an arterial site might be one example of a binder. Maybe the immobilized sprained ankle. If you've ever twisted your ankle and you get the ACE wrap to wrap it, that would be an example. We use ACE wraps also on lower extremities as a form of a TED hose to help promote venous return for somebody that has a lot of lower ankle or lower leg edema. And the advantage of an ACE wrap is if they have a lot of edema, you can wrap it, and then as that edema improves, you can wrap it tighter and differently, whereas a TED hose is a one size fits all, and if their edema or leg size changes, then it's not appropriate. As I look at three areas for bandages and binders, I would like you to think of the priority that you would put them in or have concerns for. 1 is airway, 2 is circulation, and 3 is skin. Which one is your priority, and what will you as a nurse do to assure that your patient has a proper airway with a bandage or binder? What would you do to promote or maintain their circulation or check that they have occluded circulation because of their binder? And then also think about the skin, looking at the skin, unwrapping and assessing that skin periodically throughout your cares. When we use an ACE wrap, remember we want to assess at least every 4 hours. It would be more appropriate to do it when? More often, when would it be appropriate? Remember, you're looking at color, the temperature, do they have numbness and tingling, and then do they have mobility to that extremity? So if you would note that the extremity is cyanotic, you will do what? Remove it. After unwrapping, you do not detect a pulse. You will do what? And after unwrapping, you note skin breakdown. You will do what? So think about all of these things as you use these wraps and binders that could potentially cause problems. Page 1109 in Potter and Perry talks about our hot and cold therapy. Remember, for most of these, you need a doctor's order. You can cause thermal damage to the skin if it's not appropriate. We're legally responsible for safe administration. So if you have a diabetic that is having some decreased sensation to the extremities, you would not want to give them a hot water bottle for their lower extremities. You would just put another blanket or socks on to warm up their feet. So as we look at their circulation, as we look at their level of consciousness, we need to assess that it would be safe and appropriate for them. When we look at sitz bath back in OB, that's there to promote healing and also to clean that perineal area for the woman. But remember, your heat will vasodilate. So with those larger vessels, when people that are in a sitz bath stand up, they will have orthostatic blood pressure changes. With cool, remember, we vasoconstrict. And so we would not want to vasoconstrict in certain areas as well either, because it could be a safety issue. If a patient came into the ER and they were complaining of right lower sided pain, and they said, just give me a hot water bottle. I think it's, maybe my fallopian tube, or I'm having menstrual cramps. It could be an appendix that's ready to burst. And if you would give them a hot water bottle, it would vasodilate and potentially cause that appendix to rupture quicker than it would have. So again, we have to be very careful with vasodilating and vasoconstricting effects of that. Local nerve endings within the skin are affected. With systemic heat loss, remember, a person will sweat, and to conserve heat, then the body will shiver, and also then the piloerection, or the hair standing up on arms and extremities. With wound care, if there is a written order not to change the dressing, we inspect only. You may put another ABD over to reinforce if needed, if you notice any shadowing or drainage to that area. Before we do any kind of wound care, remember to ask them about pain and medicate before causing any painful type of procedure, and then complete the steps in the order with the equipment that we need. The two types of drains that are listed here are Jackson Pratt, often called JP. They are used usually in upper extremities where we don't anticipate quite as much drainage coming out. Most of my experience has been with women that have mastectomies, and they often will come with two of them. One is labeled A and one is labeled B. As you can see in the picture to the left, the A part here is where the fluid will come in, and then through negative pressure, by having that bulb syringe or that bulb Jackson Pratt squeeze down and shut the lid, it will pull the fluid then out of that wound. So the woman would have two Jackson Pratt in, and one is higher and one is lower. And as you start doing some critical thinking, you know that the one that is lower is going to probably have more drainage to it just because of gravity. So if your patient with a mastectomy would sit in the chair and your A is higher and your B is lower, your B probably will have more drainage. I've seen where surgeons will come in and remove the top one that doesn't have as much output, and they'll leave the lower one for a day or two longer before it is removed. They are just sutured in, and so it's very important that you maintain that so it doesn't get jerked or pulled out. Some of them are taped or pinned to the gown, but if you go to do cares and change the gown, make sure you unpin it first. Again, you want to empty it when it's not completely full. You want to get to it long before that, because the only thing pulling the fluid out is by having the negative pressure or having it squeezed down. So you always do it at the end of your shift and count it as intake and output. And then you would also do it when it becomes maybe 25 to 50% full to promote it being able to work. This is the larger called Hemovac. It's mostly used on your total hip and your total knee patients. So the lower extremities, it's got a more force and more volume. This one holds up to 400 milliliters. And again, it's got the spigot at the top. You can see the man's finger pushing it down. You would empty it into a graduate or a sterile specimen cup to measure the amount of output, and empty it when it's half full. As we clean a wound, then we're looking at page 1206, where it talks about clean to dirty. You would get a clean part of that every time, and then discard what you're cleaning with and getting a new one. So you clean from top to bottom, and if it was on the abdomen, you would go from superior to inferior, so you aren't down in that perineal area or in that lower abdomen where there could be potentially different germs or organisms. And then in the other picture, they are going from inner to outer, always from the cleanest or the wound moving outward. As we look at implementation, then for the incontinent patient, we may need some special skin protection. Try to reposition that patient often. We prevent skin breakdown by not massaging over the bony prominence. We used to do that even though we thought it promoted tissue or blood flow to the area, but what we found is that it doesn't. Our prevention also is looking at repositioning with pillows and wedges, heels off the bed, all of those things that we have learned all the way through the program that help promote repositioning. Our wound ostomy nurse is going to be there to help support us, And that lateral side lying position then is the most effective way to do that. Thank you.